First of all, I would like to thank warmly Walid Al-Rabashi and Ashraf Al-Tayyar for their very kind invitation to speak about fluid responsiveness prediction, of course, with echocardiography, and in this first talk, especially for mechanically ventilated patients. And I disclose for this presentation first that I collaborate with the following companies. What are we, in fact, speaking about? Let's take the example of a patient hospitalized for community-acquired pneumonia with septic shock on first day and with lung involvement and low PF ratio. And the patient has already received saline and is under norepinephrine. The question, the daily question we have here is, should I give fluid or not to my patient? Why is that really a problem? Because we know from the early 80s that, and especially from this study in 1981, that all the patients do not respond to fluid administration by the increase in cardiac output we expected. And following that study, a lot of studies have confirmed that all patients do not respond to fluid administration. Why this is due to very basic physiology, and it's due to the relationship between stroke volume and cardiac preload. This is the Frank-Starling relationship with different slopes depending on the ventricular function, and it explains why a given increase in cardiac preload during volume expansion could result in a positive or a negligible response in terms of stroke volume and cardiac output. This is the first part of the problem. The second part comes from the fact and from the evidence that fluid overload is deleterious, is really harmful for our ICU patients. We know that fluid overload may increase the level of lung water, especially in ARDS, increase the abdominal pressure, the pressure perfusion gradient, hemodilution, it promotes the right ventricular failure in ARDS, etc. And the harmfulness of excessive fluid administration has been demonstrated in several studies. The first one was the SOAP study. And you know that in that septic cohort, the fluid overload definitely increased mortality. The cumulative fluid balance was an independent predictor of mortality independently from all the other indicators and risk factors for mortality. Septic patients, but also ARDS patients. We showed in that study again that cumulative fluid balance is harmful for the ARDS patients and increases mortality, and so on and so on. Several studies have shown that giving too much fluid also increases the lung water, and the level of lung water, as we showed in this meta-analysis coming from several studies, showed that the lung water is linked again to prognosis of our patients. Increasing lung water too much is deleterious. This is the second part of the problem, and it comes from these two elements, these two facts, that we should give fluid only if we know it will be effective. We should predict fluid responsiveness. It's exactly the same as for an antibiotic. In an ICU patient, you wouldn't give an antibiotic without being sure it will be effective. The same for fluid. Both have adverse effects and are inconstantly effective. For the antibiotic, you need an antibiogram. For the fluids, you need something that predicts fluid responsiveness. How do we do that? For many years, you know that we used static markers of preload, like for instance, the CVP, which was very popular. The principle was very simple. If CVP is low, I give fluid. If CVP is high, I don't give fluid. And the problem is that it doesn't work. The main problem And the main reason for that is that you can see on this picture that a given value, a given value on the x-axis could correspond to several levels, different levels of fluid responsiveness. So that basic physiological evidence tells us that CVP cannot predict fluid responsiveness in any way. It's the case for all the static markers of cardiac preload, assessed through catheters like CVP or also assessed by echocardiography. And it's the first important message. What are the static markers of preload we have with echo? We know it can be the E over E prime ratio, which estimates in fact the PaOP of the PA catheter, or the LV and diastolic area. Both markers of cardiac preload, static markers of preload, assessed with echocardiography, do not discriminate between patients who will and who will not respond to fluid administration, as shown in this study. Do not assess fluid responsiveness just looking at the area of the left ventricle or the level of the E over E prime ratio. It doesn't work, and it's been shown by a lot of studies. It's equivalent to CVP. Rather than CVP and all other static markers of preload, we should rather rely on dynamic indices as eventually recognized and recommended by the last version of the Surviving Sepsis campaign for septic patients. What is this dynamic approach? In fact, it's a dynamic way to assess the slope of the Frank-Starling curve at the bedside. And the principle is very easy. You change preload in any way, any intervention, any task that does that, and you observe the response in terms of stroke volume or cardiac output or any surrogate. If it varies a lot, it indicates the patient works on the steep part of the curve, and you should give fluid knowing that the patient will answer, and the opposite if there is no change with the change in preload. And all the tests, all the indices we have, in fact, work on that, except one type of indices I will tell you in a minute. So it means that we have a very simple algorithm in mind. The first, always the question, is cardiac output too low? Because if there is no lactate elevation, no decrease in urine output, no mottling, I should not ask the question, but otherwise, I ask the question, should I give fluid? Then two options. If there are obvious fluid losses, hemorrhage, for instance, great dehydration, severe dehydration, if it's the very early phase of sepsis, before giving any drop of fluid, we know the patient will be fluid responsive. No need to predict anything. Give fluid to that patient and don't waste time. But in the many other cases, we know that all the patients will not respond to fluid administration, and then we need all these tests and indices. And in the next minutes, we will review these tests and indices, especially those assessed with echocardiography, because it's our topic today, in mechanically ventilated patients, and it will be during my first talk, and in the other patients, and it will be my task during the second talk. Let's start with the pulse pressure, stroke volume, VP variations. What are we speaking about? Likely you know that. Again, it's a way to test the Frank-Starling curve slope, but here by using mechanical ventilation, because we know that in a mechanically ventilated patient, each insufflation tends to decrease cardiac preload. With ventilation, cardiac preload varies cyclically. And so just observe the results on the y-axis on stroke volume, and for instance, on arterial pulse pressure, which is related to stroke volume. If mechanical ventilation induces large changes in arterial pulse pressure, if pulse pressure variation PPV is high, give fluid, otherwise don't give fluid, or at least you know the patient may respond to fluid administration or not. All the question then is to know what you should put here on the y-axis. What is it with echocardiography? You may look at the peak of the LV outflow tract signal with pulse Doppler, or at the area, it means at the VTI, velocity time integral. And if there is a large variation in VTI or the peak of the signal, it may mean your patient is fluid responsive. It's been shown for the first time almost 20 years ago, and the threshold of positivity was 13% variation of this peak of the assessed with echocardiography. Nevertheless, first of all, it's not that easy to assess, and especially you must be sure that this variation is not only due to the fact that the signal is going away from the beam of the echocardiograph. Also, so it's not easy, and it means that if your patient has an indwelling catheter, it's much easier to assess PPV, which is the equivalent, but automatically measured by the bedside monitor. But if you have no A-line, you may do that with echo. The other limitation of that variations in stroke volume or equivalence, the main drawback is that there are many instances where they cannot be used. In case of cardiac arrhythmias, spontaneous breathing activity, and ARDS because of the low lung compliance and because of the low tidal volume. In all these instances, you have either false negatives or false positives. And the problem is that you will agree with me that it represents a lot of our patients. And in that study we just conducted, in 100 cases, we showed that PPV and SPV are interpretable or feasible in only 17% of the patients, so a minority of the patients, and it's the case also with echo. One point, in case of low tidal volume, we may have a solution which was called the tidal volume challenge by our colleague, Indian colleague Sheila Mayatra. What she did and what we did in our patients was very simple. VT was at 6, but for a minute we increased it to 8 milliliters milliliters per kilogram. And we measured PPV at 6 and PPV at 8. And we measured the variation of PPV. And we showed that if PPV increases by more than 3.5% during that increase in tidal volume, you may know your patient is fluid responsive. It might be a very easy way if you have a patient with the ARDS and just an A line, no need for measuring cardiac output. Is it possible with echocardiography, especially again when your patient has no A line? And in that study that we just submitted, we showed it's not the case. We measured the changes in the inferior vena cava variability, we'll speak about that in a minute, with echocardiography during that tidal volume challenge. The area under the RAC curve was quite good. Nevertheless, the threshold was very small. Only very small changes in the IVC variability during the tidal volume challenge could tell us fluid responsiveness. And obviously, it was a too small threshold for being compatible with the precision of echocardiography. So disappointing result with echo. Let's come at that point on the changes in IVC and SVC diameters, and I know that Professor De Backer will speak about that in his talk. Of course, it's all echo, and it's very easy because you don't need to measure cardiac output. Just look at the IVC, which is quite easy, or the SVC, which is less easy with transesophageal echocardiography. You still need to know echo, but all of you here know echo, otherwise you wouldn't be there. But keep in mind my message, and it's my point of view. These are the less reliable indices of fluid responsiveness we have. It comes from many small studies and that large French study showing that the area under the RAC curve was not very good for detecting preload responsiveness, either for the IVC variation, look at the area under the RAC curve, or even the SVC variation, the area was 0.75, not much better, lower than PPV and all other indices of preload responsiveness. And perhaps the reason why is that this IVC variation does not depend only on the Frank-Starling curve. Why does the IVC varies with ventilation? Two mechanisms. First, because in case of preload responsiveness, the pressure inside the vessel, meaning the CVP, varies with ventilation. But it's not only that. The other element is the compliance of the IVC, which should be larger in case when it's empty. So you understand that many other elements than preload responsiveness intervene in the mechanism. Compliance of the IVC, intra-abdominal pressure, transmission from the thorax to the abdominal pressure, etc. So it's not a pure marker, it's not a pure dynamic index of preload responsiveness. Furthermore, it has almost the same limitations as PPV and SUV except cardiac arrhythmias. You can't use them in case of spontaneous breathing, low lung compliance, and low tidal volume. The last test we may use in mechanically ventilated patients is the respiratory occlusion test or tests. It's very easy to perform. What is the principle of that? The principle is that in a patient under mechanical ventilation, as we have seen before, every insufflation tends to decrease cardiac preload. With ventilation, the venous return tends to decrease at each insufflation. And so the principle of the test is that if you stop mechanical ventilation at end expiration for a few seconds at the PEEP level, the cyclic impediment in venous return decreases. For a few seconds, the cardiac preload increases. If you wait enough for the transfer of that preload bolus across the pulmonary circulation, the left ventricular preload increases. And if in turn stroke volume increases, it means that both ventricles are preload dependent. It's another dynamic way to assess the Frank-Starling curve slope with ventilation. And in that study more than 10 years ago, we showed that if cardiac output increased by more than 5% during an end expiratory occlusion test, we could say the patient was going to respond to fluid administration. It's very easy to perform if you have a continuous and direct display of cardiac output, as for instance with pulse contour analysis. Look at that example. You stop ventilation at end expiration, wait for 15 seconds, the duration is important, and directly look at the change in cardiac output. You see, it's very easy if you have the display of the real-time changes in cardiac output, as for instance with pulse contour analysis. But of course, all these patients are not equipped with that. Today, we have several studies with the test, and we recently published a meta-analysis taking all the studies with the test, less than passive leg raising, less than pulse pressure variation, but significant amount of studies. And overall, you see the area under the RAC curve and compare it to the IVC variations, for instance. Is it possible to assess the test with echocardiography? It's been suggested by the results of this study of a French team. Nevertheless, the changes induced by the test are very small, and they are likely not compatible with the precision of echocardiography. This is why, in that study, the last I show you, we added to the end expiratory occlusion an end inspiratory occlusion, which was supposed to decrease stroke volume in preload responders. And we assessed the response with the amplitude of the VTI, of the velocity time integral. And we expected that if we added both changes induced by end inspiration and then expiratory holds, we could detect preload responsive patients. And it was the case. If we used only the increase in VTI during end expiratory hold, the area under the red curve was good, but the threshold was a 4% increase in VTI, which is very small. Echo is not precise enough for detecting that. By contrast, if we added the effects of end inspiration and then expiration, the threshold was much higher and more compatible with the precision of echocardiography. Of course, so it's not very easy, one must say. It's easier if you have a direct measurement of cardiac output, but otherwise with echo, you can do that. The limitations of the test are that it's not possible to do it, of course, in non-ventilated patients, but also in patients who have too strong respiratory efforts and who will interrupt the 15-second end expiratory occlusion. And in any way, you need something that estimates cardiac output. Nevertheless, it might be usable in a lot of patients. These are the tests we may use and indices we may use in mechanically ventilated patients. Regarding the other tests, we will see that in my next talk. And with this, I thank you very much for your attention.
Thank you very much, Professor Xavier. It was very, very nice presentation as usual. Walid, we have 4 minutes to go to the next presentation. If you get any question from the attendees. Let me start by asking Dr. Xavier Monnet, from this review, so we could understand that comparing the invasive or semi-invasive methods to the available methods in echo, you are still not in favor of going with echo in mechanically ventilated patients to see if they are fluid responsive or not. What I understood is it's difficult and might be not recommended to go with echo parameters, VTI, or maybe the changes of the IVC or superior vena cava might be slightly better. Do you agree with this conclusion, or I misunderstood?
I wouldn't say not recommended. Regarding these respiratory tests, they might be valid with echo, especially the changes in the peak velocity of the VTI, and especially the changes with the end expiratory and inspiratory occlusion tests. These tests are valid, fully valid with echo. I'm just saying that they are less easy to assess with echo than with an A-line or a direct measurement of cardiac output, but there are some patients where we don't have any A-line. Think about, for instance, low-income countries where septic shock patients have no A-line at any time. Just with an echograph, which is of course expensive, but it's for all the patients, just with an echograph, you may assess that respiratory changes induced by both tests. My point is that if you have an A-line and for the end expiratory occlusion test, if you have a direct measurement of cardiac output, it might be easier than with echocardiography and as reliable.
Yeah, and
Okay.
of course, everybody working in ICU would see that if we have arterial line and the technology of following the cardiac output with the arterial line technology is much easier to go with compared to the spot echo use. Yeah, Walid, go ahead.
Okay, so after this conflicting data or loads of background information, is there any algorithm make it easier or feasible to assess the fluid responsiveness?
I would say, again, only regarding mechanically ventilated patients, that the algorithm would be, is cardiac output too low? If yes, could I increase it with fluid. I assess fluid responsiveness, and there are two options. If there is no mechanical ventilation, if there is mechanical ventilation, no spontaneous breathing, no arrhythmia, no ARES, I may use the respiratory, the cyclic variability of pulse pressure or the peak velocity of the VGI. In the other cases, I should use something else. The end expiratory occlusion test or the tests I will speak about in my next talk. This will be the very simple algorithm.
Okay, so next question is the IVC variability feasible for measurement in a spontaneously breathing patient, or paralysis is mandatory?
I'm really looking forward to listening to Daniel de Backer about that topic. But in my point of view, you need a ventilated patient and a regularly ventilated patient because it all depends on the respiratory efforts. During the last night, when we were sleeping very quietly, likely our IVC didn't change that much. Take a patient, even a full patient in the emergency room with respiratory distress, the respiratory efforts are so strong that they may induce a variation of the IVC just because they are very strong, even though the patient is fluid unresponsive. It all depends on the force of the respiratory efforts. To have a standardized one, you need a ventilated patient.
Perfect.
Thank
I
you very
think this is the
much,
time
Xavier.
now to shift to the next lecture. So I'll give the mic to Dr. Ashraf Al-Tayyar.